here we are to decide how to choose what kind of maintenance therapies that we will be using. I just wanted to say that, even though we are treating all ovarian cancers as one, they are not one disease. And today the focus of the talk will be on these high-grade serous ovarian cancers, which are BRCA mutated or driven by the BRCA pathway. But even among the high-grade serous ovarian cancer, they are not a single disease, and we see that some of them have a worse outcome, which are the ones which are mesenchymal subtype, because they are driven by the VEGF. And whereas the immune reactive subtype, they have a better prognosis. So although we don't understand completely and we don't triage our treatment based on this, but we know that the different kinds of ovarian cancer will have a different biology. And what is important is why in the whole of ovarian cancer, we have seen that the basic armamentarium of medical oncologists in ovarian cancer till now has been platinum, and we use platinum in front line, second line, after relapse. So the reason for this is that a large majority of these patients have deficiency, or what we call BRCA-ness, in the DNA repair pathways. So even though only about 10 to 15% of them have germline BRCA mutation, they have either a methylation or mutation in other pathways, which lead to them becoming deficient in DNA repair, and which leads to platinum sensitivity and what we will now discuss about PARP sensitivity. So what is important to remember is that as we were discussing, that it is advanced stage ovarian cancer patients, their overall 5-year outcome before the advent of all the targeted therapies was only about 30%. Of course, we have a very small percentage of people who go beyond 5 years, as only about 25%. For large majority of the patients, they will relapse at a median of 12 to 15 months, and the median overall survival for these patients used to be just about 3 years. And of course, as we have discussed that, you can choose your patients for neoadjuvant chemotherapy or primary debulking surgery, and they all would receive 6 cycles, a total of 6 cycles of chemotherapy with paclitaxel and carboplatin. And for a long time, we had been remained stagnant there, and therefore, the obvious question is, how do we prevent relapses? And if you look at maintenance therapy, at least taking cue from breast cancer, so many of the patients used to have some kind of maintenance therapy to prevent relapse. And for ovarian cancers, 2 strategies which are available to us are the use of PARP inhibitors, which is basically looking at because these cells are not able to repair their DNA, and we block another mechanism of DNA repair, and of course the VEGF inhibitor, bevacizumab. So how do we choose this? Before I come to how we choose, I would also like to stress upon what are the tests that we decide to use it. One test which was already mentioned is whether they have a germline mutation in BRCA1 or 2. So that, of course, we send the patient to genetic clinic for pre and post test counseling, and we test the blood for germline BRCA1 or 2. However, it is, as I said, that germline is only 15%. Another 20% have somatic, that is, they don't carry the BRCA mutation in all their cells, but they have BRCA mutation in the tumor tissue. As I discussed previously, that there are other pathways of DNA repair, and if they are involved, so that would also lead to a phenotype. They don't have BRCA mutation, but their phenotype, or they look like, or they behave like BRCA because other genes in the homologous repair pathway are affected. And similarly, they could have methylation. So what is it that we do to detect this BRCA-ness? So that is what we do to check a homologous recombinant deficiency. And there are various tests available, and of course the standard is to use the Myriad My Choice, and different studies have used different cutoffs. So it is important to understand that when we are sending for HRD testing, because we will be basing our decisions on that, that the tumor tissue should be adequate, and not just a lot of times they have a lot of inflammatory tissue. So all of that needs to be documented. So it is important to understand that for ovarian cancer, what is validated is the HRD. So what is the difference between an HRD and an HRR? So homologous repair pathway has several genes. So suppose, as I said in the previous one, you have other genes involved like RAD51, PALB2, CHEK2. These are other genes which are involved in the DNA repair pathway. So suppose I have a mutation in any of the genes, and I see that there is a scarring, or what we detect by this HRD test, that the effect of that gene. So the effect of the gene is what we test when we're doing an HRD. Now it may so happen that one of the genes is affected, but another gene or another gene in that pathway takes over its function. So the effect, in effect, it is able to repair the DNA. So in that case, it will not be sensitive. So what is important is that in patients with ovarian cancer, what has been validated to correlate with platinum sensitivity is the HRD and not the HRR. So if you just find a mutation in, say, RAD51, but the HRD is negative, then that is not an indication to start her on PARP inhibitors. Of course, it is intriguing, and maybe we learn more that in other cancers, say something like prostate cancer, HRR is approved, but not so in ovarian cancer. So I think it is important to know which cancer we are dealing with before we decide on PARP inhibitors. So that was just a thing about test, because we'll be talking about these tests. And now moving on to the different maintenance strategies, as I said about bevacizumab. So we had basically two pivotal trials of use of bevacizumab. And both of these were in patients who had undergone primary cytoreduction, and they started bevacizumab after one cycle and continued it for all the 6 cycles, from cycle 2 to cycle 6, and then for almost a year after that. So in the long term, it has been seen that the use of, and all of these are in at stage 3, stage 4 patients, it has been seen that after giving it for a year, the median benefit in the progression-free survival was only up to around 2 to 3 months. And so in the long term, it was seen that really there was no difference in the overall survival in the intent to treat population. But in the high-risk population, that patients whom an optimal cytoreduction could not be achieved, or who had stage 4 disease, that is the subgroup which benefited from bevacizumab. Now, it is important to look at these numbers, which, even with the use of bevacizumab, the overall survival that you achieved, median overall survival, is close to 39 months, which is, around 3.5 years. So even with the use of bevacizumab in stage 3 to stage 4, the overall survival achieved was around 40 months. And I showed you the initial subtypes in the beginning, so can we choose better? Although this is not in clinical practice, but maybe some years down the line, we can have that patients who are mesenchymal subtype, they do better. And what was very interesting is that we all know patients, when we give neoadjuvant chemotherapy, some of them will have an excellent response. All ascites will disappear. The CA-125 will crash from 3,000 to 30. And those are the patients who are able to be optimally cytoreduced. And we know that there are some group of patients who don't have such a response to chemotherapy. So, they looked at an objective way of assessing that, and basically looking at what is the rate of fall of CA-125 and checking it over, over a period of 100 days or around 3 months on 3 different time points, and looking at the rate of fall. And basically, what this whole thing means is that if they have an excellent response to chemotherapy, which they have classified as a Kelm score of less than 1, those patients, even if they are high risk, stage 4 suboptimally reduced, will not actually benefit from bevacizumab. So if the whole thing boils down to if it is a stage 4 or a suboptimally cytoreduced, and they have not had a response to chemotherapy, is the situation where they would benefit from bevacizumab. So slowly we are coming down to a very small and maybe a select subgroup where we could use that. And the GOG 218 was another study of use of adjuvant bevacizumab, and almost similar results, that overall no survival benefit except in the stage 4 disease. And I would just want you to focus on that those with BRCA1 and 2 mutation, I mean, there was no differential response. And as I said, the overall survival in a general ovarian cancer is around 3 or 40 months, whereas here with or without bevacizumab, it was just around close to 60 months, or close to 5 in a BRCA mutated population. So that is just something to remember, that BRCA mutated population do well even with platinum. So then coming on to PARP inhibitors and the mechanism of synthetic lethality, which we have always discussed, that because one of the pathways of DNA repair is damaged because they have BRCA or BRCA-like mutation, and if we damage the other mechanisms also, and on top of it we hit it with platinum, the cell is not able to repair, and therefore they have synthetic lethality. So now in the frontline setting, we have several trials which have looked at the use of maintenance PARP inhibitors after we have completed 6 cycles of the chemotherapy. Now important is like the olaparib has been used mainly in germline or somatic BRCA mutated patient. It has been used with bevacizumab in the POLA1 study, or another drug rucaparib. So basically we know that different studies have used a different subgroup. Essentially we have the longest survival data with olaparib, where the 7-year survival with olaparib is close to 67%, and which is something we never heard of. We knew that 5-year survivals were just 30%. But mind you, this is in the only BRCA mutated subgroup, right? If you have the PFS overall, I mean, in a non-selected population, then it has improved from almost 51 to 56 months. Of course, we have FDA approval for olaparib and niraparib. We have data for rucaparib also in the frontline setting, but it's still presently not approved, FDA approved, though we have the data from the phase 3 study. So, this is just to highlight that, we have even at 7 years an extended follow-up, that these patients, we are achieving an improvement in overall survival. What was reassuring was that the rate of AML and MDS was less. That is a concern whenever we are giving patients PARP inhibitors. In long term, they do get AML or MDS. And another thing which I forgot to mention was that these PARP inhibitors are given for a period of 2 years. And, but the benefit is extending much beyond 2 years. So that is something that we need to see. And as we were discussing, the maximum benefit is derived by those who have a germline BRCA mutated. But if you have an HRD deficient tumor, they also derive benefit, but the magnitude of benefit is less. So if you have a HRD deficient, there is a PFS improvement from 8.2 to 19.6. However, if they are proficient, there is hardly any benefit, and that is really not recommended now. And the same thing we have seen is there is a trial comparing addition of bevacizumab to olaparib. Now really we don't know how much that adds to the benefit, and as in all trials, what they have shown is that those who are germline BRCA mutated, they derive the maximum benefit, followed by the ones who are HR deficient. Those who are HR proficient, meaning that the cell can repair its DNA, they really do not benefit from PARP inhibitor, and if anything, it is detrimental. Okay, so that was the thing. And I think it is similar, and a meta-analysis of all these trials have also shown that only the germline BRCA mutated and the HR deficient patients, they benefit from PARP inhibitors, whereas if, as I said, they're HR proficient, they don't benefit. So it is important to know how do we select patients. And of course, now generally, in most other cancers, you will see immunotherapy coming up. Immunotherapy has really not been a player in ovarian cancer, and most of the trials have been negative. There is a trial, but it is a small study which has, put everything together. You go with all guns blazing. I don't know what you will have in, future for these patients. So that is combining all durvalumab, bevacizumab, olaparib, but I think that results are too premature. Uh, Before I move on to how we select, I would also want to say that all these three PARP inhibitors, rucaparib, niraparib, and olaparib, they are although the same class of drugs, but they have small differences, and most common side effects for them being anemia and fatigue. And almost 1/3 of these patients required dose modifications for that. I mean, there are some differences as per group, like rucaparib has more of transaminitis, niraparib has some cardiac dysfunction, and of course anemia and fatigue is more common with olaparib. And another important thing to keep in mind is when you're prescribing PARP inhibitors, they are CYP3A4 inhibitors. So something as common as like, metformin, ciprofloxacin, which will interact with your drug and may cause side effects. So please keep that in mind whenever we are giving. That's true not only for PARP inhibitor, but for any drug. So then how do we choose? I mean, this is something that I've kind of just collated that, if you have a patient with advanced high-grade ovarian cancer, how would you go about deciding on their maintenance therapy? So you test for BRCA mutation, and I think if you do get a germline mutation, this is the group which has the maximum benefit. If BRCA is wild type, germline is wild type, then you do an HRD testing. Most of the HRD tests also take into account somatic BRCA, so I have not written that separately. If they are HR deficient, again they are candidates for PARP inhibitors. Addition of bevacizumab in this group, even though it is approved, we don't really know how much they will benefit because, but there may be a small subgroup who are so-called BRCA, that is, they don't have a response, or a wet disease where that could be considered. For a HR proficient patient, if they've had an optimal cytoreduction, if you do an excellent surgery as was just previously shown, and they are HR proficient, I think the present treatment paradigm would be just to observe them. In future, whether a whole of this combination helps needs to be seen. If it is HR proficient, but it is a bad biology disease, advanced stage, and optimal cytoreduction could not be achieved, that is probably where one would choose bevacizumab. And in case there is less time, I would just want to say that in I think in recurrent ovarian cancer, we are moving from calling what is platinum resistant and sensitive to what is platinum eligible and ineligible. Essentially, somebody who's like 5.5 months after their first relapse, but has had a previous response to platinum or is BRCA mutated, they would probably respond well to platinum again. And the same question comes in platinum sensitive relapses as well, which one of them to use. And essentially what all of this basically means is that both bevacizumab has shown a benefit, and so has PARP inhibitors. So the only, and patients who have germline BRCA mutation, they do benefit from PARP. Important thing is that when we use PARP in the second line, the rate of MDS or an acute leukemia is close to 8%. Now, that is almost 1 in 12 of these patients have the risk of developing an MDS or, leukemia, which is almost fatal. So that is a thing which needs to be considered. And like in the frontline setting, even in the recurrent setting, the maximum benefit is there for patients who are germline BRCA positive, less for those who are BRCA negative. And another important thing which I wanted to say is that when you're using PARP in the frontline setting, our definitions of platinum sensitivity and resistance change. Because if a patient who is on PARP inhibitor progresses, their response to platinum may not be so active. So I think another bottom line is that previously, for some years back, the thing was that if you have a platinum sensitive relapse, a non-platinum agent should not be used, and for that matter, even PARP inhibitors should not be used in this setting. And although this was previously approved, presently that approval has been revoked. And can you use PARP after PARP? Probably, but I think that is something which needs more attention. So I think I'll come to my concluding slide is that in patients who have platinum-resistant disease, the one thing that you should remember is that they are not candidates for PARP inhibitors. And that is one area where you can, do with use of bevacizumab. And as you know that whatever advances we make, tumor gets better of us, and there is BRCA reversal and there is resistance to PARP. So I think there has been a revision in the summary of what has been approved in the frontline setting, and as I mentioned that there's a withdrawal of approval for use of monotherapy of PARP inhibitors. So I think this would be my take-home message that if you have in the frontline setting, if they are maintenance bevacizumab is only if they are HR proficient and they are high risk. For all patients who have germline or BRCA mutated or HRD would prefer to use a PARP inhibitor. And same as the patients who have relapsed. So after you give them first-line platinum-based chemotherapy, you would want to use a PARP inhibitor if they have a germline BRCA mutation. If not, of course, also you can use bevacizumab. But having said, PARP beyond monotherapy is not approved. But having said all of this, and also in the platinum-resistant setting, as I said, that there is no role of PARP, so it is bevacizumab. But having said all of this, I would also want you to remember that all these targeted therapies come at a cost. And when we are discussing the toxicity benefit, that also should be discussed. And of course, the magnitude of benefit, cost, side effects, all that should be taken into account before we consider treatment. But I think hope is always there. Thank you.